Like I said, it's a real short one this month. A lot of it we have gone through a bunch of times already so far this year. We have one more Con Ed in June, and then we'll have our break for the summer, so it'll be good. So what we're going to kind of review today is a little bit about the anatomy and physiology of the heart, the electrical pathway of the heart, and then breaking down some rhythms, mainly the blocks, talking about our tachy protocols, our Brady protocols, and our cardiac arrest. And really, that'll be it for today. So pretty good, pretty slow, but by the way, let's see, Mike Lettieri and Kevin Schumann from Wilmette put this together for us this month. So, all right, just as a brief reminder, the cardiac anatomy, we have the atria and we have the ventricles. The right side of the heart is probably our low pressure side of the heart, otherwise known as the pulmonary side. The left side of the heart is our high pressured side, pushes blood out of the heart to the rest of the body. The right side goes to the lungs and then comes back in from there. Some of these walls can be obviously damaged due to lack of oxygen if one of the coronary arteries gets clogged or blocked for whatever reason. Our right coronary artery, remember, that feeds the inferior wall of the heart, and it does feed part of the SA node, part of the posterior wall. Our left coronary artery basically separates into two different vessels. We've got our anterior descending and the circumflex. The anterior descending, if we're looking at it, V3, V4, V1 and V2, the septal wall, the anterior wall. And then the circumflex is our lateral wall. You can look at it as lead 1, AVL, V5, V6, and also in some people the posterior side. So the main thing we really want to kind of concentrate on today is the electrical activity of the heart. Now and how it correlates with the EKG that you guys go ahead and when you take a look at the complexes. So the SA node is the natural pacemaker of the heart. We're looking for an intrinsic rate of about 60 to 100 beats per minute. If we see a P wave on our QRS complex, our EKG, we can say that it's usually originating in the same sinus node or in that general area. And we do have the wandering pacemaker, which can make our P waves look a little bit different. Just remember the rule for the wandering pacemaker is that you'd have to have 3 or more different looking P waves in order to be calling it a wandering pacemaker. From there, the electrical activity goes down the internodal pathways, and it also has a fascicle that kind of reaches over to that left atria to go ahead and depolarize or contract the left atria. Blood then is going to go ahead and go from those atrias down to the ventricles through your bicuspid and tricuspid valves. Now, once the electrical activity gets to this AV node, the AV node is the gatekeeper of the heart. It slows that induction a little bit so it allows the ventricles time to go ahead and adequately fill up. What's nice about the AV node also is that if the AV or the SA node is not working, the AV node hopefully will pick up. It's got an intrinsic rate of about 40 to 60 beats per minute. If we go ahead and if the SA node doesn't fire and the AV node picks up, generally we will see what we call a junctional rhythm. The P wave may be absent, may be inverted, may be embedded, or after the QRS complex. So you kind of have to look at everything when you're going through there. And then it goes down the right and the left bundle branch. Right bundle branch has just one fascicle. The left bundle branch breaks into 2 separate, an anterior and a posterior fascicle when we go ahead. Now, what's nice is that the Purkinje fibers or those left bundle branches, if for some reason the SA node doesn't do its job, the AV node doesn't do its job, the heart can kind of do one of those like idioventricular or junctional escape beats, or just try and go ahead and contract those ventricles. But the rate's going to be a lot slower. It's going to be 20 to 40. And obviously a lot wider when it comes from the ventricles itself. So we're going to look at the 4 main blocks here. The big thing to remember with blocks, it's all about the rules. And we're looking at our P wave and our PR interval. That's really going to be your deciding factor as far as what type of block you actually have here. So we'll start with our first degree heart block. The rule is that if that PR interval is greater than 0.12 or 0.20 seconds, we would consider it to be a first degree heart block. Now at this point in time, the AV node is holding up that impulse a little bit longer. We may not know for exactly what reason or what the cause of it is, but we know it's just holding up a little bit longer. People live with first degree heart blocks all the time. Doesn't necessarily mean they're going to be bradycardic. Obviously they can. But we have people with first degree heart blocks that do have rates of 70s and in the 60s and so on. But with these patients, if you actually go by our protocols, most of them are asymptomatic. They're pretty stable. So our treatment is just going to be to monitor them. We're not doing a whole lot. It is allowing a little bit more of the ventricle to fill, stretch a little bit more. That can lead to some other problems later on down the line. By dilated ventricles, it can, the more you stretch something, they say the greater the contraction, but after a while, it's just like elastic. It wears out, and the contraction is not as great as what it is. Now with our second degree type 1, again, we're looking at our PR interval. With our second degree type 1, you'll start off by maybe seeing a normal PR interval. As the rhythm goes on, it gets longer, and drop. Now, I'm sure most of you through school have gone through normal, longer drop. It doesn't have to be in that fashion or that format. It can be a normal, a longer one, and then it actually can drop a beat. So kind of take a look. It's a good idea to have a good, more than a 6-second strip to go ahead and take a look and identify the second degree type 1. Now, this does become a little bit concerning just because of the fact that for some reason that AV node is not allowing that electrical impulse to make it down to the ventricles. And anytime we have that block, that can be concerning to us. Most of the time, we're just going to monitor these patients. Obviously, unless they're really symptomatic. Majority of them aren't, not saying that they can't be, but a majority of them aren't with them. If it is really low and they are symptomatic, then we could go ahead and try some of the other things. Like, well, you could try your atropine. You can go ahead and try pacing if they're unstable. When we get to the second degree type 2, our higher blocks, these become more concerning of a block. Again, remember your rule. Take a look at your PR interval. This one's not the best second degree type 2. I've got one that's a little bit better in here, but what we're looking at is you're going to see normal PR intervals. Your PR intervals are going to be consistent throughout your strip that you're looking at. The only thing that we're going to notice on this is that you might have sometimes more P waves than you do QRS complexes. It's basically dropping the beat, or it is not allowing that impulse to go down through the ventricle for whatever reason.
He's dropping the beat.
Oh.
Sorry.
Depending on how drastic this is, sometimes you might have a 3-to-1, 2-to-1, 4-to-1 conduction rate. And a lot of times if you've got something, you're going to actually see it more often than just one time in the middle of a strip. In our second degree type 2s, if these patients are unstable, atropine mainly is not going to work on them. It doesn't work on a third degree block either. It is in our protocol to at least attempt, but we'll talk about what atropine does in just a moment here. On our third degree heart block, again, taking a look at our rules, our PR intervals are not consistent. You will have a P wave before every QRS complex, but the PR intervals are all over, and nothing correlates together. If you take a look at this first complex, we've got a PR interval quite long, maybe 20.24, or no, 0.44, something there. This one actually looks pretty normal, the second one, another long one. And you can actually see there's a P wave embedded in that QRS complex. When you look at it, your QRS complexes are actually going to march out. And then if you actually go ahead, you can march out your P waves, and your P waves will actually march out. But the big thing to remember is that the atria and the ventricles are not working together. The atrias are not contracting, allowing blood to fill the ventricles, and then go ahead and push it out to the rest of the body. It goes ahead and is kind of all over the place. So with these patients, a lot of them may be unstable. We're going to need to pace these. Atropine will not work in these patients. So when we take a look at our protocol, the big thing we have to ask ourselves anytime someone is bradycardic is, why are they bradycardic? What is the rationale? We don't want to just get tunnel vision and say, oh, the patient has a heart rate of 26, automatically go ahead and give atropine and pace. We actually just reviewed in class on Thursday. We had a student who brought in a rhythm that was a 26 rate with tall peak T waves, and they went straight to pacing on this patient. After we had discussed it a little bit at the hospital, they found out the patient had a potassium level of almost 7, and obviously they needed to monitor this patient a lot closer to make sure they didn't go into cardiac arrest. But it was, if they would have, doctor said, if they would have tried a fluid bolus, because the patient's condition was they were nauseated, vomiting, poor intake for the last week. And so at the hospital, they went ahead and gave him some calcium chloride, some sodium bicarb, some other stuff to go ahead and bring down the potassium levels. And the patient's rate came right back up. So some of the things you have to ask is, why are they bradycardic? And then we have to try and fix the problem. And a lot of times that can fix the rhythm right along with it. Other things to consider, are they on a medication? Are they on a beta blocker or some other medication that may be slowing their heart rate? Maybe they're just really in great shape that their heart rate resting is normally 54. Are they symptomatic or asymptomatic, stable or unstable? Those are the types of things that we're going to look at before we actually start treating our patient. So if you look at our protocol here, if we have a patient who is stable, meaning blood pressure is above 90, there's no altered mental status, there's no other signs and symptoms as chest pain, shortness of breath. Now, you don't have to have this whole list of things going on in order to say, oh, they're unstable, or oh, they're stable. You know, take a look. You might have someone whose blood pressure is 88 systolic, but their mental status is really good. They don't have any chest pain, no shortness of breath. And so with those patients, we don't want to jump right into the unstable. Take a look and, you know, really see what your patient is doing. Are they perfusing okay? What is their cap refill? Now, if our patients become unstable, maybe blood pressure is less than 90 systolic, they have altered mental status, they have chest pain, shortness of breath, things that make them not doing so good. Perfusion is not well. Remember, stable medicate, unstable electrocate. So with this, we're going to attempt 0.5 milligrams of atropine. Now remember, atropine probably is not, well, it is not going to work in our higher degree blocks. They're second degree type 2 or third degree heart blocks. With these patients, we'll go ahead and move into our pacing if they don't improve after the atropine. Put the pacer pads on. We're going to set the pacer at a rate of 80 and start working our way up with the milliamps until we get what we consider capture. In order to get electrical capture, we should see one pacer spike before every QRS complex. And make sure at that point in time, once that's happening, that we have the mechanical pulse of 80 right along with it. With this, we don't delay medication, or we don't delay pacing to administer medications, depending on how bad they are. But if you have time, I know the protocol still says that, and we put something out about 6 months ago with the Versed, just so you guys are aware too. I sent something out, but we don't currently have vials of Versed. We have a couple pre-fills, but I don't know what's going to happen as soon as we run out of the Versed. I talked to pharmacy yesterday, and they're getting kind of low We'll have to see where we're gonna go from there if they can't get some more Versed ordered in here. Don't forget also, pacing is gonna be kind of painful, so it's not a bad idea if the patient is complaining of any pain to administer 1 mic per kilo of fentanyl for these patients. Now, after you've got all this going and your patient's blood pressure still is not improving, maybe you want to consider a dopamine drip. Remember, dopamine, it's actually very easy to go ahead and set up. It's easy to figure out your dosage for it. If you know your patient's weight in pounds, if they're 180 pounds, drop that last number, the 0, you're left with 18. Subtract 2, you have 16 drops per minute for 5 mics. And that works with, any weight, as long as it's in pounds for these patients. You can try another dose of atropine, but remember too, with atropine, if they end up having too much or too fast, you can cause paroxysmal bradycardia and you can slow the rate down even more. Anybody have any questions on the bradycardic rhythm? All right. So with our atropine, we take a look at what does atropine do. Well, it's a parasympathetic blocker. If you remember our sympathetic and parasympathetic nervous systems, the sympathetic nervous system is our fight or flight, the one that increases our heart rate, increases vasoconstriction, dilates our pupils. Our parasympathetic slows things down. Feed and breathe is another way to describe it with these patients. Slows the heart rate down, and then with these patients too, the other thing that's an anticholinergic medication, I have a hard time saying that. Things to think about, we use it for those that have organophosphate poisoning overdoses, maybe those with weapons of mass destruction. It's in our Mark II kits or duodotes now. They're all in one. It is mainly blocking that parasympathetic nervous system from taking over and slowing everything down. So it's allowing the conduction to go through that AV node a little bit faster. Things to kind of watch out for, patients may complain of, dilated pupils. It actually will go ahead and reverse the sludge that we talk about, salivation, lacrimation, urination, defecation, GI issues, and emesis. And it dries the patient out quite a bit. So they might complain of headache. They might have complained of, being really, really thirsty, flushed skin.
Did you know that Mark hit himself with a Mark II kit?
Why?
Didn't think we'd have live agent to mess with. I had it upside down. I got shot in my thumb. I had to pry it out.
Don't worry.
Oh, it messed me
You
up.
messed him up good.
You can laugh. I got a good sense of humor. I got hit in the thumb. Ouch.
I'm all for some.
How many bags did they give you?
Oh, I went nuts. I went the Mad Hatter disease.
Did you really? I was
Oh, I
just
went
going to
nuts.
ask.
I was combative. I was choking people. My blood pressure was like 240 over 180.
Holy buckets.
Yeah, I went crazy.
Don't worry, it was expired though.
But yeah, now I climb walls and
Well, at least we know how far out it being expired that it's still active.
still active. Works really well.
We had one of our old instructors when I was up at Vista. He had thought he had a EpiPen that was a trainer and went and did this number with it and went right straight through his
It's
hand.
stuck in my bone. I had to get pliers to pull it out. You can laugh. I got a good sense of humor now that I'm not.
Now that you're not.
Any other drugs you'd like to test out?
Yeah, you got it.
Well, thank you for giving your body the science to identify how long a medication is still valid after the
The fight or
expiration
flight
date.
was the thing that it messed with the most. I'd go on a call like, I want out, I'm done. I'm walking back to the station. They're like, but then I became safe.
Did you really?
Kind of.
Maybe.
You just made them.
I see that you still have some residual effects.
No, that's just me normal.
Oh, that is funny. Sorry.
No. Glad I'm funny like a clown.
Yeah?
Like a big dumb animal.
Yeah.
Yeah, I really don't think I'd want to meet you if you were having that whole
I
combative
was
issue or
combative,
anything.
yes. I choked out a couple
He's
people.
country strong. Country strong.
And then you have no reasoning. You just want to fight. It's kind of like.
2-0 officer. The patient was oxygen level 34, 35.
Okay, so this is our pacing protocol. Kind of goes over everything we kind of talked about. Remember, you do have to have your 4-lead on when you're getting ready to pace somebody. Front and back or normal position if you want. Set the rate at 80, turn up the milliamps. The big thing to remember though is that once you gain that capture, make sure you document what you were at and don't shut your pacemaker off once you have capture. I see that a lot of times people are like, oh, well, blood pressure's back up, everything's fine, let's shut it off. No, don't do that, just leave it on. Let the hospital take care of it. All right, the next rhythms, the tachyes. We've got narrow complex and wide complex tachycardias. And again, it goes back to figuring out, why are they tachycardic? Are they having an anxiety attack? Are they freaking out over something? Are they running a fever? Is it medication that they take? Is it cardiac disease that they have? Those are the types of things we're going to try and figure out so we can cure or fix what might be going on with these patients. Again, we want to determine, are they stable or unstable? Symptomatic or asymptomatic when we take a look at them. So this medication, adenosine, is what we're going to use, which is going to slow the heart down. It slows that AV, or slows the conduction time through that AV node, tries to go ahead and re-interrupt the rhythm to basically reset the heart. We give it in 6 milligrams. If 6 doesn't work, we move on to 12. If you've taken ACLS, you know that they give a second dose of 12. We do not do that within our system here. They're going to have a brief period of maybe asystole. I know as you're sitting there watching it, everybody gets a little bit anxious. Also, make sure you identify with your patient and let them know what's going to happen and how they may actually feel. It's not very kind if you've got someone who's awake and alert and you're doing this to them without letting them know what's going on. So I'm just going to switch right over to this one here first. So, well, actually before, I want to, sometimes when you take a look at it, we use the number 150 beats per minute to say anything above it is SVT. SVT is kind of a garbage term. There's a lot of different rhythms under that SVT umbrella. You've got AV nodal reentries, you've got multifocal atrial tach, AFib with RVR. The big thing is, until we slow that rhythm down, we're not going to know what we're dealing with and how to treat it. So we're hoping that the adenosine would start to work with these patients. I do the National Registry exams, and the National Registry actually, in their static cardiology, they give a rate of 150 beats per minute. And the patient information underneath it is a 22-year-old male patient who's been out in the heat for the last 4 hours at football practice, drinking water, and kind of leaves it at that. And we see so many people think, well, this is cardiac in nature because I'm in a cardiac station. I have to go ahead and use adenosine or Cardiolor, one of those things. Remember again, sometimes it's just as simple as removing them from the heat, giving them some fluids, letting them sit down, cool down a little bit, and then the rate may come down. So your history behind every one of your patients is going to be very important as a cue of how to treat your patients. So when we have that rate greater than 150 beats per minute, and we've determined that it may be cardiac in nature, and the patient is currently stable, good vital signs, mental status is good, they may have some fluttering in the chest or some minor type signs and symptoms. We'll start off with some Valsalva maneuvers. If those don't work, then we move on to our adenosine. Adenosine can be given, we prefer to go in the AC, just so it's close to the heart. The half-life is 6 to 8 seconds, so we want it to get to the heart a lot quicker. And then you can follow it up with a 20 cc flush. There's various different ways to go ahead and give it. You can push it, you can turn on your bag and squeeze your bag and push it in that way instead of hooking up, whatever works, but you want to push that flush behind it. Now, if our patient doesn't respond to that medication in approximately 2 minutes, we can go ahead and try another dose of 12 milligrams. But if it's not working, then we can say that it's probably maybe atrial in nature. We need to move to a calcium channel blocker, relax some of those coronary perfusion, and we'll move on to our verapamil. Verapamil is 5 milligrams IV push. Please push it slow. You can cause bradycardia, you can cause hypotension if you're slamming it in a patient. So we don't want to do that. We don't carry calcium chloride to reverse the effects of verapamil if we push it the wrong way. Now, if our patients are unstable, again, stable medicate, unstable electrocate. With these patients, we're going to go ahead and use cardioversion. Now, in our protocols, we have it set up with the monophasic numbers. This chart here that's in the protocol book, I believe, needs to really be updated because everybody's got new monitors. The big thing to remember is whatever your manufacturer states to go ahead and do for cardioversion, defibrillation is what you want to go ahead and use. Now, cardioversion obviously is a little bit different than defibrillation. You're going to hit your sync button, and that's going to flag your R waves. So it hits or depolarizes that ventricle during the depolarization phase. We don't want that electricity to hit during the repolarization phase. You might end up, when they're in the refractory period, they may end up going into VFib if you do that. But with it, we try 100 joules. If it doesn't work, we go to 200, 300, 360 joules. And that's the order that will go in with patients who are unstable. Now, patients who have AFib, we have a lot of patients that are, live with AFib every day. A lot of your elderly patients, it's not uncommon for them to have AFib. But do they have a history, or is it new onset? Some things to, kind of think about. Are they taking their medication? Are they compliant in their medication? Are they compliant in taking their Eliquis or Coumadin or whatever medication that they may be on for that? With our rapid AFib, so a lot of people say, well, what's rapid? What are we looking at? We actually say that about 120 beats per minute with signs and symptoms is considered to be rapid AFib. So with these patients, if they're, maybe 130 beats per minute, they're stable, blood pressure is good, but the rate's just going way too fast. Maybe they have some lightheadedness, dizziness, weakness. We'll go ahead and try Valsalva maneuvers. If they don't work, we can move on to our verapamil at 5 milligrams. Slow IV push again. You guys won't ever be pushing that second dose because you'll probably be on your way back to the station by the time the patient is ready for it. With the unstable patients, we're going to cardiovert. Now, we do the same thing, 100, 200, 300, and 360 joules. Again, don't forget Versed if you're going to go ahead and cardiovert somebody. And then again, if they are feeling some pain or complaining, you can give some fentanyl along with it. I do know a lot of the doctors, when you mention verapamil on the radio, are going to say, oh, just hold off. There's other medications that are a little bit better that they may prefer to go ahead and push when they get there. Even determining if they're ready to be cardioverted. Some of the things that we worry about with patients that have AFib, if they're not compliant with their medications, might be some type of clot that may be in those atria. And do we knock that loose when we reset the heart and it goes in and causes a heart attack or causes a stroke, depending on where the clot actually may be coming from. So I know a lot of the doctors, they get a little bit reserved when you start asking to go ahead and cardiovert or even push for verapamil with these patients. I don't know, with this one here, just myself, I always make a call to medical control and ask them what they really want me to do. I don't know, this is just one of the areas I just get a little bit nervous when I start cardioverting anybody with AFib. Even though they do it all the time at the hospital. So, our verapamil, calcium channel blocker. It relaxes the coronary smooth muscles. It's going to go ahead and decrease the SA80 node conduction, trying to slow down that rate between those areas. It can dilate the peripheral arteries, so that can cause hypotension in our patients. Obviously, it's not a medication for our blocks, so we don't want to use it for them. It comes packed, well, like I said, I think ours comes packaged 10 milligrams, 2.5 milligrams per milliliter for these patients. We don't want to give it to patients who have WPW, sick sinus syndrome. Most patients who have WPW will actually know about it already. We would probably never catch that in the field unless you're really good at taking a look and reading 12 leads. But patients after administering it, headache, watch for the hypotension, watch for some dizziness for these patients. And it can, one of the other things, cause an AV block. So our Y-complex tachycardias, we can break it down into monomorphic, meaning everything looks the same, or our polymorphic / torsades. Polymorphic, it's coming from multiple focal spots, and they all look a little bit different. So I'm just going to go to this slide instead. This is probably the easiest. Actually, I think you guys had a call not too long ago where someone did start amiodarone on the field, maybe this last week. I think our student was with and was talking about what a great job. He was really excited. You guys had some feedback. But if you have a patient who's stable, now VTAC, the heart, it takes a lot of energy to have VTAC, and a lot of hearts are not going to tolerate it for very long. If you have a person who is stable, we're going to go ahead and try the adenosine first, mainly because SVT with a barren conduction can actually mimic Y-complex tachycardia. More than likely, it's not going to work. So why that's being pushed, you guys can go ahead and move on to the amiodarone. We're going to put 150 milligrams in a 100 cc bag of D5W, and we're going to run it in over 10 minutes. Use your macro tubing for this, and if you put it in a drop, maybe just a smidgen faster than 1 drop a second, it'll go in over the 10 minutes. If we have a patient who's polymorphic Y-complex tachycardia and stable, with these patients, again, stable, monomorphic, polymorphic, we will use our amiodarone drip for them. Where things change up a little bit is the unstable. With these patients, we're going to go ahead and cardiovert first at 100 joules. Don't forget about your Versed, 2 milligrams every 2 minutes to a max of 10. If we cardiovert at 100 and we notice it didn't work, we're going to stop, we're going to try the amiodarone drip, and if that doesn't work, then we'll move on and go up to 360 joules for our cardioversion. Where a lot of times people get confused is that they may start off with a person who's stable. They've got the amiodarone drip going, and then all of a sudden the patient becomes unstable. So they cardiovert, but now the protocol says, I've got to go ahead and start another amiodarone drip. Obviously that time frame is not going to work out for you guys, but even if you finish the drip and you've cardioverted, we're not going to start a second drip. Just go on and finish your cardioversion. Again, remember that you're going to hit your sync button, so you're flagging that R wave. You don't want to defibrillate them. I will tell you with polymorphic Y-complex tachycardia, putting the sync button, you're going to end up having to defibrillate them. You're not going to your sync button is not going to pick up on a lot of those R waves. So with these patients, don't forget about pain management. Cardioversion is painful if they're still pretty conscious and alert with it. So our drug that we're giving here is amiodarone. Amiodarone is an antiarrhythmic medication. We use it for 2 different times. One, we use it for the stable patient and even in the unstable, for those that are Y-complex tachycardia. We use a half a dose, 150 milligrams, and then we run it in as a drip. But if we have a patient who's in VFib, VTAC without a pulse, we're going to give 300 milligrams, and this is going to be IV push for these patients. Some of the things to be cautious and watch out for: if your patient does go ahead and convert, watch for that prolonged QT interval. The easiest way to identify a prolonged QT interval is taking a look and seeing if the QT interval is greater than half of the R to R interval. If it is, contact medical control. You don't want that QT interval getting too long. Probably going to end up having you stop the amiodarone from there. So it does have a negative inotropic effect. It can cause hypotension, vasodilation for these patients, so you want to make sure that you're really assessing their vital signs every 5 minutes with them.
That packaging, I'm pretty sure it's that one, comes like that, and then I think we're getting, who's on the ambulance for, are we getting just 50 milligram vials too?
Are you really?
For amiodarone or mag you're talking about?
I thought it was that order, no?
I haven't seen any different packaging.
No,
Amiodarone?
maybe it was a different one. One of them has two different, I'd have to look at which drug it is. I thought it was amiodarone.
Well, and you know what, in this whole medication, I'm going to be putting out an order today. We've got 50 vials or 50 prefills of dextrose. I talked to Dr. Lott yesterday. We're going to be switching over to D10. So I've got the protocol for you guys already. I'm going to be sending that out this afternoon. They're going to give you guys the prefills of the dextrose for right now, but they're going to run out soon. Dr. Lott would prefer to be with D10 anyway, and so, so would I. All the other systems, when I was talking to them, they're doing well with their dextrose. They've got a pretty good supply, but they will run out in time too. So it would not surprise me that as we rewrite the protocol, we just change it to D10.
You're gonna change the SOP like right now? Or?
I have a new SOP that I will be sending out to you today, that if you get a 250 bag of D10, we'll be administering that instead of an amp of D50.
So you're gonna send a whole new SOP out with a new date?
Not a book, I'm going to send you a new page.
Okay. But there has to be an updated version. Right?
We're working on that right now, yes. You're not going to get a full book.
No, I know. Is there a printout like sticker you can do? Or?
We don't do the stickers. We send out the protocol to the departments. They'll have to pull out the old one and put the new one in.
So if we look on our target solutions for the newest SOP, is it going to have like tomorrow's date, or is it going to say February 1st still?
That book will be just like what you have. I'll be sending out, just like we did with the sepsis protocol when we updated that, we sent it out, and most departments pulled the old one out and put the new one in. But I know, I can send you an electronic version so you can update it.
I just want to, know what date I'm looking for.
Okay.
Is the most, because I think we had a problem a long time ago where
Yeah.
you're like, February 1st, 18 is the current one, but they didn't tell us there's two added.
Well, and if you look at it right now, what did I show you before with the pacing? It's still set value. And that's coming from this book here, but we sent out an order saying that if you don't have Valium, use Versed.
That was temporary though, right? No, it's permanent.
It's permanent, yeah. No one's been able to get Valium. So, we're trying to take the protocol book, and this has been the big hot topic of conversation. Obviously, everybody wants the small protocol books for their pockets when they're on the ambulances and that, and they're really nice to be able to do that. But we want to have a live protocol book that we can send out a document, digital format with updated dates, so that you have the latest version
I'm fine with that.
at all times.
Yeah, that's all I'm with.
Make it that.
Yeah, make an app where it's always updated.
Well, there was an app, and the guy that was doing it, no one knew who was doing it, but
It was like $15, right?
well, when they first started, he was charging $11.95, and we're like, who is this character? He's making buku bucks off, and people were buying it. But then it came out on, if you search SOPs, you just pick your state, you pick your region, and it's a different app. And this guy's got pretty much every protocol throughout the United States on this app. So, but we want it to be a fluid, live protocol book. So it's updated pretty much every day. If something changes, we can update
Yeah,
it.
that's all I'm looking for. Sometimes I've gotten that, I'm like, no, that's not the current one. I'm like,
What am I supposed to do? Yeah. So I will see what we can do about getting that out for you. So, did you find it, Gary?
Oh, you know he found it.
PPP, it's, I don't know the exact name of it,
You got it?
but,
We got it back here.
the,
It says it was last updated on February 14, 2018.
Every helicopter protocol ever. This is the best ever.
Yeah, so we'll see what we can do about making sure you guys have one that has a proper date on it for you.
Yeah, that sounds like, and if it's changed, then we know. it's-
See, if you just memorize all of these and know them off the top of your head, you wouldn't have to worry about it.
Which ones am I supposed to?
Quit changing.
The whole book. But that would be no fun.
Bring back what's
is that the tip?
Yeah, I got it.
Yeah, we're in the process right now. We just finished OB and peds and the cardiac ones. Now we're working on the medical ones, so re-updating. So maybe in 5 years we'll have it done, and then it'll be ready to change again. So, MIG sulfate, another medication we use for our wide complex tachycardia, otherwise known as polymorphic wide complex tach, torsades. It does go ahead and inhibit smooth muscle contraction, but we use it for other things also. We use it for our pediatric asthmas. In the hospital, they'll use it for adult status asthmatics. They'll use it for patients who are preeclamptic. We are making it now with the new protocols. We want to add it in to give it when they're preeclamptic to prevent any seizures from coming. But currently, right now, we use it if they're pulseless. VTAC or VTAC, wide complex polymorphic torsades. We're going to give 2 grams, and we're going to put it in 100 cc's at D5W. And then we're going to run it in over 5 minutes. So this is going to run really quick. Make sure you're using the macro tubing for it. Let's see here. Do not use it in patients who have heart blocks or women who are in actual active labor. Okay. Some of the things that can cause hypotension, flushing, drowsiness, respiratory paralysis, so kind of watch out a little bit for this. All right, last slide, pretty good, huh? Is our cardiac arrest. We have a patient, they're pulseless, not breathing. The big thing to remember is the very first thing we do is start CPR, start compressions. You guys do your pit crew CPR here, you know how you have it set up through your department. The minute your defibrillator is hooked up and ready to go, we will go ahead and defibrillate. We don't have to do 2 minutes of CPR first and then review the rhythm and defibrillate. So, CPR is going on, we defibrillate as soon as it's ready. Someone else is getting the IV established, gets ready to go. We stop, we take a look at the rhythm. We only check a pulse if the rhythm that we're seeing cannot produce a pulse, or can produce a pulse. So like PEA, VTAC, we want to check for a pulse. Otherwise, we go ahead and defibrillate if it's pulseless, VFib, VTAC, and then right back into CPR. Now, when you're organized and you're starting your pit crew CPR, if you can give your first medication right away when you start that new round of CPR, it really helps you guys identify what your next medications are and what your time frames are. Because if you go ahead and you push your first epi, 1 milligram of epi 1 to 10, you've got 2 minutes. You review the rhythm, no pulse, you defibrillate, you start CPR again, then you're set to do your amiodarone. 300 milligrams IV push. 2 more minutes, then you're ready for that next epinephrine. That way a lot of people are like, well, how long has it been since our last epi? If you do it right away when you start the CPR, it gives you the nice time frame. Once you've given your 2 doses of amiodarone, then it's just every other cycle you're given an epi. And it helps, like I said, it really helps that you're not giving too much epi all at once. Don't forget about switching the roll of the compressor every 2 minutes. Getting the airway secured. Again, airway secured. If you're getting good chest rise and fall with the bag valve mask, that's fine. And then if we get return to spontaneous circulation, well, let me back up. If you have a patient for 20 minutes, after 20 minutes, you decide your transport, if they're in VFib, VTAC, we're going to package them and get them ready to go. If they've been asystolic for 20 minutes despite your ALS care, that's when we're going to call medical control and ask if we can go ahead and withdraw resuscitative measures. PEA, systole, very easy. Our only drug is epi. Every other cycle you can give an epinephrine. So CPR, stop, assess rhythm, still asystole, start CPR, give an epi. Next one, just CPR. Next cycle, give CPR and an epinephrine. And then just kind of rotate every other one. Don't forget, you guys, in your cardiac arrest, your H's and T's. Try to figure out, why did my patient go into cardiac arrest? Were they hypoxic? Are they on some type of drug? Did they have an MI, PE, for whatever reasons? And try and go ahead and figure out if there's something that you can do to correct it. Are they a dialysis patient? Do they need sodium bicarb? So once you go ahead and do that, make your determination.
Bolus tube or PA?
What's that?
Bolus tube.
Bolus of what?
Saline.
Start an IV. I mean, if they're hypovolemic, you're going to give a bolus if you think that's the reason why.
No, I deleted it, it's not protocol.
Right, shift tools.
If
Yeah. Gary's getting jealous of you.
Yeah, stop it.
Yeah. I got a twin. I told you.
Sorry. Rose.
no, I mean, start your IV, and if you think they're hypovolemic, they're dehydrated, they've been nausea, vomiting, yeah, give them a flu bolus. Otherwise, just turn on your IV. Not wide open.
Gary will counsel you after this.
On your time.
Maybe you need some remediation.
Then we'll bump, we'll bump, we'll bump,
All right.
we'll bump, then we'll bump.
So that's it.
Yeah.
That is it.
No.
We'll bump.
Okay, we need to get you